Ladies and gentlemen, distinguished scientists, clinicians, researchers, and guests, it's a great honor to welcome you to this conference dedicated to one of the most profound scientific and human questions of our time: longevity. For centuries, humanity has asked not only how long we can live, but how well. Today, the question stands at the crossroads of biology, medicine, technology, ethics, and society. Longevity is no longer a distant aspiration. It is an active, measurable, and rapidly advancing field of scientific inquiry. Recent advances in molecular biology, genomics, regenerative medicine, artificial intelligence, and preventive care are reshaping our understanding of aging. We increasingly recognizing aging not simply as the passage of time, but as a complex and, to some extent, modifiable biological process. One that can be studied, influenced, and potentially treated. This conference brings together experts from diverse disciplines because progress in longevity cannot occur in isolation. It requires collaboration between basic scientists and clinicians, between technologists and public health experts, and between innovators and ethicists. Our shared goal must be not only to extend lifespan, but to extend health span as well. Over the coming sessions, we will examine cutting-edge research, clinical innovations, and emerging technologies aimed at preventing age-related disease and improving quality of life across population. Equally important, we will address the scientific, social, and ethical challenges that accompany these advances. Let this conference be a forum for rigorous discussion, open exchange, and bold thinking. May it inspire new collaborations, challenge established assumptions, and help translate scientific diversity into real-world impact. On behalf of the organizing committee, thank you for joining us in this important dialogue. We are honored to have you here and look forward to have the insight and innovation that will emerge from this conference. Welcome to the conference and welcome to the future of longevity. And with this, I declare this conference open. I am now introducing our first speaker, Dr. Andrew Shuen. It's my pleasure to introduce our first speaker, Dr. Andrew Shuen. Dr. Andrew Shuen is a longevity-focused physician and medical geneticist specializing in precision medicine. He holds both MD and PhD degrees, completed his residency in medical genetics and is currently an assistant professor at McGill University, practicing at the Jewish General Hospital. He is also the founder of Genome, where he works at the intersection of genomics, advanced biomarkers, and personalized interventions to extend health span and prevent diseases. Today, Dr. Shuen will take us on a deep dive into precision medicine, exploring the lessons the genome can teach us about individualized care and future of longevity medicine. Dr. Shuen.
Hi. Thank you. Thanks for the introduction. I'm such an honor to be here. Me and Shua go back to my time in during residency, like 10, 15 years ago, when we were doing our medical genetics together at McGill. So it's a great pleasure for me to give this talk on precision medicine and tales of the genome. It's actually a personal story I'll be going into for some of these slides. So I started with my undergrad at U of T, did my medical school in Ottawa, then residency, and then I did a PhD afterwards. So a little bit unconventional and my PhD took 10 years to complete actually. And I just recently started my uh, my position here at McGill at the Jewish last year. So these are my traditional medical roles. But I started to branch into integrative medicine, and I find that just so much more fascinating. For me, it's just a passion for me to be in the integrative space, trying to prevent medical chronic conditions rather than just kind of fix things haphazardly. So what I want to talk about is some of the genetics of health and longevity, what we've learned from the supercentenarians and healthy agers. So because there's such a wide background of people, I'm just going to quickly go over a little bit of genetics. So what is this genome? The genome is basically your your blueprint, what makes you you, what makes you unique. And we're all composed of about 3.2 billion base pairs of DNA. For men, this is kind of a microscopic overview of your genetic makeup. If you look under a cell, in a cell, you could see your chromosomes, which is basically these little squiggly lines here. And then you have 23 chromosomes. X and Y make you a male, XX make you female. And so if you kind of unwind the chromosome, which is basically a packaging of all of your genetic material, you could see the gene here. And you could kind of think of it as analogous. So the genome is like your book. Your chromosomes are the chapters of the book. The gene is the sentence. Introns are the filler spaces, the punctuation marks that tell you how to express, or some of the regions tell the body how to express those words, the exons, and then DNA is just the alphabet. So when we look at the genomes of these extremely long-lived individuals, what we find is that they have a lot of protective mechanisms that prevent them from really aging, even though they may have some factors, some genetic factors that give them disease risks like Alzheimer's. They have something that buffers against these harmful mutations. So they have rare and protective coding variants in things like insulin signaling and AMPK signaling, which slows down their aging. They don't really age very quickly. And this is what contributes to their exceptional longevity. So this person was 117 when she passed away. The other things are favorable cardiometabolic profiles, low-grade inflammation, efficient immune responses, beneficial microbiomes, and decelerated epigenetic clock. So they don't age very quickly, but we do see telomere attrition, so their telomere lengths, the things that cap the ends of the chromosomes, they are pretty short, but this seems to not affect how she ages. And then for the healthy elderly, so the people who are 80 and over, but without any chronic issues, they seem to have a different genetic profile. They lack risk factors that would normally cause disease. So they don't have the bad genes that cause heart disease and Alzheimer's or diabetes. And they looked at these from they compared them from the general population to those with the healthy elderly population. And they looked at their whole genomes. And then what they found was just that they didn't have any risk factors for Alzheimer's and heart disease. And then just this study came out like yesterday or a few days ago. And it was like a huge, it was published in Science. About 50% of your genome predicts how long you will live. this number was kind of blew my mind because in the past there was 20-25% it was thought to be, but those numbers were based on your longevity, but it included extrinsic factors, so environmental factors that caused like a bus hitting you in the street or something random, infections that may have caused you to pass away early. But just based on your genetics alone, if you can avoid all those accidental factors, about 50% of your genetics predicts how long you will live. So it is a huge contribution, and knowing your genetics is extremely important to kind of give yourself the most optimal advantages in life. Yeah, so this is just the data showing that. So if you remove the extrinsic factors, you get a correlation of 0.5, or which is 50%. And they showed this for other cohorts of people. So in the Danish and Swedish cohorts, it's about the same. You could see that if you remove extrinsic mortality, it goes to about 50% for both cohorts. And this was the uncorrected estimates, and then you can see that it was like 20%, and now we know that it's about 50%. All right, so what can we learn from your own genome or your genetics? What we can do is proactive test screening. So we're looking at just the high-risk genes for cancer and heart disease, and this allows you to go for your early detection and prevention. And it's only like $600, but it can really save your life in many ways. Polygenic risk scores are extremely valuable too. So it can tell you what your predispositions are for chronic conditions, Alzheimer's, heart disease, hypertension, diabetes. And then pharmacogenomics, which medications will work best for my body. So avoid side effects and give yourself the right dose at the right time. And then nutrigenomics. How does my DNA respond to certain diets? Do I have a deficiency in vitamin D? Am I sensitive to caffeine? That sort of stuff. But what we'll talk about today, because I only have 30 minutes, we'll just talk about proactive screening and polygenic risk scores. So one of the most famous examples is Angelina Jolie, who had a mutation in BRCA1, and she had her breast mastectomies and oophorectomies. So, and then Christina Applegate as well, who has a mutation in BRCA1. So people with BRCA1 mutations are at high risk of breast and ovarian cancer. You could see here the lifetime risks associated with mutations in this gene. It's not just women. Men can also get cancer at higher risk. So it's about 20% for prostate cancer. Pancreatic cancer is about 3% for carriers. And then there's another gene called BRCA2, which also increases your risk for breast and ovarian cancer for women and prostate cancer for men. So this is just one of the many genes that are on these panels, proactive screens. There's about 178 different genes that are tested. These are the two most famous ones on this panel, but testing for them could change your life because then you get earlier screening and potentially go for prophylactic mastectomies like Angelina did. So after Angelina made her announcement that she had BRCA1, a lot of people went and sought genetic testing at referral centers. So you could see a huge spike in 2013 compared to the baseline in prior years. And then prophylactic mastectomies were also increased after her announcement. So what are the chances that someone in the general population will have a mutation in a gene on one of these panels? This was the question they tried to answer. And so it's about 11% from this study of 1,281 patients. And these patients are from like Mayo Clinic Executive Health Program. So like they're just healthy general adults who are healthy, no real issues, and then they just wanted to pay for these tests. So 11% of these patients had a mutation, and of these, 51% or about half of them didn't even have a family history of the disease. So they in the public system they wouldn't have been even referred to see a geneticist. but they had access to it because they could pay for the test themselves. And then this other paper recently in 2021, I just highlighted Leah Velcher and Jessica Gu because they're from MedCan in Toronto, and it's where I also worked for a period of time. But what they saw was out of 10,000 people tested, 10,478 people tested, 15% of people had a mutation in one of these genes, in the 168 genes that are on this panel. And 6.2% had a high impact gene. So one of the very classic genes like BRCA1 and 2, BRIP1. So there's something that can be done to reduce your cancer risk or avoid sudden death from a heart disease. So these are things you could find out just from a genetic test. So I had my own genome tested, of course, because I'm a geneticist. I just didn't know where to go for mine. And then I found out during that time, the Nebula Genomics had something. I didn't go with 23andMe or because there was just, you don't get enough sequencing depth. But here at 30x whole genome sequencing, I thought for $500, why not? But I got like a likely pathogenic variant in TP53, which is a cancer gene, a really bad cancer gene, and it freaked me out a bit. So here's like the scale. So pathogenic means it's gonna give you cancer, and likely pathogenic 2 is pretty bad. So when you have a likely pathogenic or pathogenic, you're able to undergo cancer screening. You could get the cancer screens. But for variants of uncertain significance, you don't really know what the effect of the DNA change is. So you don't really go for any changes in management. You won't get your cancer screens if it's just the VUS, basically. And then benign and likely benign are harmless changes to your genome. So Li-Fraumeni, which is the TP53 mutation that I thought I had, causes breast cancers, sarcomas, brain tumors, leukemias, and they're usually childhood onset. So I was like, oh, that's strange. I never had any of those when I was growing up, and neither was my parents. There's no family history of cancer, so early cancer. So I was a little bit skeptical about this variant. But I had my parents tested, and I went to Invite and got my results there as well, and everything was clear. So just kind of a lesson. Go to see a geneticist or a genetic counselor. Don't do these tests all by yourself because you're just going to run into a lot of anxiety when you get into these things from these tests. So yeah, I had it came out likely pathogenic TP53. All right. So the next thing I want to talk about is the polygenic risk scores. So we talked about the high risk. So TP53, BRCA1 and 2, it's very rare in the population, but if you have it, you're at high risk of cancers. So we were just talking about the rare allele causing Mendelian disease. But on the other side of the spectrum are common variants, but they only contribute to a little bit of that disease, like the risk factor for that disease. But it's the sum of all the risk factors or protective factors that really affect how likely you will develop a certain condition, like breast cancer, prostate cancer. So basically, it's looking at all the variants in the whole genome, all 23 chromosomes, and then counting which ones how many you have and what's the how much risk does it add to your overall risk. And then for those who are at high risk, they have just a lot of different risk factors that they've inherited from both parents. And then you could, based on this kind of percentile, it's usually expressed as a percentile. So something came up on my whole genome. So there was it says here 96th percentile for prostate cancer here. So these sorts of things, there is a family history of prostate cancer. So it is something that I believe in. And you can translate that prostate cancer risk into your lifetime risk based on curves. So these are curves like 10-year absolute risk based on your percentile. And if you're at the highest end, your absolute risk goes up, obviously. So knowing all of this, I'm like, okay, so I know I'm going to be at risk. What are some of the steps I can take? This is where the proactive medicine comes in, and you try to live your life to lower that risk. And knowing your risks ahead of time really helped that. Yeah, so here we just, because of the polygenic risk, and then you have your family history, you could add that and then be even more accurate in terms of risk prediction. We only have about 10 to 20 conditions where we have good data on like the types of conditions you might be at risk for. We just don't have enough people we've tested, sequenced to know exactly for other conditions what that risk is. But for coronary artery disease, breast cancer, type 2 diabetes, prostate cancer, atrial fibrillation, and colon cancer, there's good data on polygenic risk scores. And that can add to what we already have for monogenic diseases. And there's only one company right now, I think, with Allelica, they have a good platform where you could get your monogenic variants like BRCA1 and 2, and then the PRS scores, and then integrate those two genetic data together to give you an overall risk. So which whole genome sequencing would you go for? There's like the one I went with, Nebula, for $495. Sequencing.com has one for $400, all the way to $6,300 at Medcan. Fulgent has one for $2,500. It's just, there's kind of a wild west in terms of whole genome sequencing. But what I would do, so this patient I'm just going to talk about, she's 43. She came to me. She went with sequencing.com, had her genome sequenced. She had unexplained abdominal pain, but nothing really could explain. Yeah, she went for all the imaging, all the blood tests, everything came back normal. And then she went for sequencing.com, and it came back likely carrier or likely detected mutation in this gene for hereditary pancreatitis. So she was extremely worried. Oh my God, I'm gonna have pancreatitis for the rest of my life. Just a ticking time bomb, she said to me. And this is the variant that was identified. It's a low penetrant pathogenic variant. So it's not always going to cause pancreatitis, but there's increased risk for it. But then we did the genetic test with a clinically approved, CLIA-approved lab, Fulgent, and it came back completely negative. Even that variant was not detected. So you have to be aware that the ones for kind of the ones that are direct to consumer don't have that stringency as the ones that we use in medical genetics. There's a lot of false positives that come up from direct to consumer testing. So in summary, there's a lot of genetic factors that are protective in the extremely long-lived, but there's also a reduction in harmful mutations in those with healthy lifespans, healthy lifespans. And then proactive screening and polygenic risk scores could help you determine if you're at risk and then mitigate them if you know you're at risk by screening, lifestyle changes. So if you want to work with me and just contact me at Genescence, I could kind of guide you through this whole maze of genome and genomic testing. There's just a lot of information out there, and sometimes you can get lost, but it's otherwise, yeah, it's good information, and it's something you should all be aware of. All right, and yeah, do I have time? I don't know if we want to talk about. Do you have any questions? All right, so yeah, Okay.
I want to know, do you know if any of the companies sell your data? Because oftentimes the genetic companies.
Yes, like 23andMe, it was bankrupt and then sold, so that all the genetic data got leaked somewhere. But if you go with like something that's clinical, like at a clinical level, that data is secure. Yeah, and you can download it yourself, but then I wouldn't upload that data that you've just downloaded to any site, because some sites do allow you to upload the data back and then have it analyzed. Yeah, but yeah. Mm-hmm.
The polygenic risk scores, when you put them all together, are you using them like sort of synergistically if you have a bunch of pathogenic together versus?
Yes. Yeah, you're integrating them together with the monogenic. So you get a very, very accurate risk score for your lifetime risk for only for certain conditions, not everything. Yeah. I think there's just 10 or 20. So actually, so the other thing I was gonna talk about was like something that's happening in the States right now. They're using all that information, but doing it even before birth at the level of the embryo, and then you could tell which embryo of the 100 that you sequenced will have a disease like neurodevelopmental disorders, hereditary cancers, birth defects, and then polygenic stuff like atrial fibrillation. And so these are like the 20 conditions that we could reliably predict, I would say, with polygenic risk scores. And it's really for the European population. It's not so much for the Asians, Africans. A lot of the whole genome sequencing data come from the European population, like the UK Biobank. So it's more accurate for that population, whereas it's less accurate for Africans, for example, and Asians. So this is happening. It's kind of a little bit worrying, but I don't know. So you could predict. So if you select the best 5 embryos, you could select the ones with the lowest risk of certain conditions, like breast cancer, for example. And this is directly from their website from Orchid. I was just, yeah. And then we have like gene therapies and genetic engineering coming too. So sickle cells now treatable with genetic engineering, and then so you can kind of see where this is gonna go. Maybe potentially you could insert longevity genes into your embryo one day. If you don't have it, you're like longevity genes are pretty rare unless you have 100-year-old grandparents on both sides. You might not kind of be lucky and inherit them, but with genetic engineering, that could be possible. You could manufacture it into your children. So, anyways, so this is just kind of food for thought. Yeah. Uh-huh.
Do you know if they've ever sequenced any people from the blue zones?
Yes, so there's a study from the Italians where they sequenced the blue zones. They had lower risks. They had very robust DNA repair mechanisms. So that's one of the things that increased the longevity of Italians. In Sardinia, it's one of the blue zones. And there's another study from Brazil where there's a lot of genomes that were sequenced. And those, I forget what they did, but there's just a lot of protective factors for them as well in the Brazilian cohort and the Italians. And then, of course, Okinawa. So Okinawa has a FOXO3 gene that's protecting them from stress. They have cancer. This one gene is really good for longevity if you have it. And usually you're also shorter. You're not very tall, which is part of the Asian phenotype, sort of. But just FOXO3 is one of the longevity genes. Yeah.
Any more questions?
Okay. How long was that? Thanks, everyone. Okay.
Our next speaker. So, our next speaker is Dr. Khashayar Rafatzand, also known as, he said, Dr. Khashi. Dr. So Dr. Khashi is an Iranian-Canadian diagnostic radiologist with extensive expertise in advanced imaging, MRI, and healthcare leadership. He completed his residency in diagnostic radiology at McGill University, followed by subspecialty training in MRI at Harvard University. He has served as Director of Body MRI at the University of Massachusetts, Director of MRI Value and Quality at the McGill University Health Center, and as Site Chief Director of MRI and Fellowship Director at Lakeshore General Hospital in Montreal's West Island. Dr. Khashi has also completed advanced leadership training through Harvard Law School and McGill International Masters in Healthcare Management and Leadership, and is one of only 2 radiologists in Canada honored as Fellow of the Society of Advanced Body Imaging. He is founder of ISMI, a private imaging procedure and longevity clinic in West Island. Today, he will guide us through how imaging and biomarkers technology can be integrated to provide a more complete and personalized approach to longevity medicine. Dr. Khashi.
Thank you very much. Can you hear me? This is okay. All right. First of all, thank you very much for the invitation. Shua, thank you very much. Dr. Shambedi, it's a pleasure. Thank you for the honor. I feel I'm very passionate about. Of course, I have my own prejudgments and biases about this. So this talk made me actually do a recent literature search about everything. So everything is up to date in 48 hours. I don't know what came out in the last 48 hours, but up to 48 hours, we're up to date. These are my disclosures. That's my clinic. We do all of our full body MRIs at RadiMed, where I'm a shareholder. So there's a financial interest here to disclose. Now, why does this conversation matter? Because as you heard, so the direct to consumer longevity is everywhere. It's wild west. I agree with that. But so lots of testing, but not necessarily more understanding. And longevity medicine promises insight, but misunderstanding it, especially with bad expectations, creates harm. And not really competition about with the technologies. Just like pain management, longevity requires setting realistic expectations. So we're going to talk about these highlights about what proper longevity medicine will do, some nature of aging and cancer. So some key definitions. Longevity is just about the length of life, how long a person lives, and does not imply quality of life or functional health or anything. Then we have the health span, which we heard about before. It's a portion of life spent in good physical, cognitive, and functional health, free from major disease or disability. And this is the goal of modern longevity medicine. Doesn't serve anyone if you're 95 and disabled. And lifespan is the simplest of all, just the total duration of life, regardless of health state. There is a big lack of consensus, even on the definition of health span. 187 articles have 113 different definitions. So you can understand that standardizing anything is hard. And then health span is a concept. Now we have to operationalize it. We have to define its parameters. So people have used different things: chronic disease, disability, performance limitation. Only 2 definitions take into account the quality of life. Now, at least in North American, or let's say, first world, quality of life is extremely important, and we take it to extreme with kind of a medical assisted dying. When somebody is years, but they don't like the quality of life, there's an exit option. So that kind of emphasizes the importance of the quality of life. Then we have preventive medicine, precision medicine, and personalized medicine. I want to talk about precision medicine, which is spoken to a lot, but the precision medicine talks about a specific treatment for a group of people. It's the personalized medicine that talks about a single individual. So there is a difference between the two. We know what the chronological age is, how old I am. I'm almost 52. Biological age is how my body is. My brain MRI tells me I'm 57 and a half. My epigenetic test tells me I'm 5.1 years older than I am. And my Spotify says I'm 10 years older than my age. So, there are different ways, but I'm older, it looks like it. So longevity medicine is an emerging healthcare discipline focusing on early detection, preventive measures, and personalized approaches. So the most personal you can get is with someone's genome. We already had a great talk about that. And the aim is to extend your health span. promote healthy aging. Like, aging is not something that we think about eliminating or stopping or reversing it. It's just maximum really slowing it down. This slide is a bit technical. It's from New England Journal of Medicine. But what I want to emphasize is that longevity medicine most likely will never fall under the public system here in the US, anywhere, to be handled. You know, it's like health systems deal with population-based guidelines and don't deal with the individual. The reason is because of the aging and because the increasing cost of care, we're gonna see less and less budget available to take care of major chronic diseases like diabetes, cancer, you know, kidney failure, et cetera, and less money will be left for longevity. So therefore, longevity is going to be probably always funded by personal funds or by profit-based enterprises. So why do we screen? And just screening has important meanings in different areas. I know in Quebec, the regulators are very sensitive about that word, but we're going to use it here as a medical term. Screening is not prevention. Screening does not prevent disease. It doesn't eliminate uncertainty. And you know, here's my little take on it. Nothing prevents disease from happening. Nothing. As long as we breathe, the disease is right around the corner. Screening is also very different from diagnosis. And now, this is a very important part of divergence of some of the longevity technology that we have, where there is easier to screen than to diagnose. So it says, you know, we just want to detect things early enough. Not too early, not too late, but just early enough to intervene. So this is important. We want to improve outcomes. Therefore, we need to somehow measure these outcomes. We're going to talk about biomarkers. I'm not a biomarker person, but liquid biopsy, for example, is now deemed an existential threat to radio. Thank you. And this is just like the markets, all the people who are working in this biomarker field, massive market. The biomarkers measure biological signals. They can be different molecules, different elements, and they detect risk or change at the earliest level, or that's their promise. Some strengths and limits, they can detect things very early, that's a strength, may indicate risk before the symptoms appear. And this is the promise for any longevity test or preventive test. The problem is not all signals coming out through there means disease, and it requires validation and clinical correlation. So that's the area of active development of everything. The wild west that was earlier referred to is where these two interact, where signals that come out don't necessarily mean anything, like the 43, was it 43? 53? The TP53 gene that you almost had or you didn't have, and then somebody has to kind of figure out what it means. So I'm only going to talk about validated metrics. Thank you very much. So the biological age clocks. Okay, this is kind of like a bucket of products. They represent the most advanced longevity metrics that we have. You can measure a bunch of things. Epigenetic, this is what I took that tells me I'm 5 years kind of older than I am. These are the different types. For the metabolic biomarkers, you can see the names here. For DNA or epigenetic markers, you can see them here. These outperform chronological age-trained biomarkers. What do I mean by that? By that, I mean I scan my face and the AI tells me I'm 42. Or I go in one of those things in the gym and they measure, and that's what I actually did, a very good gym, expensive thing. I went on it and I drove it for 2 minutes. It told me I was 45. I was so happy. And then a week later, my epigenetic came back, and I aged 10 years. So that kind of matters. Between these tests, these two have shown the strongest association with mortality and frailty outcome. So frailty is another very important thing. I think Charith is going to talk about the muscle mass as the investment. Frailty is extremely important. It's probably one of the least talked about factors in longevity. So this is from the Grim Age, and this is from the Metabo Health. There's a frailty score. This is actually from a paper by John Afilalo, the Montreal cardiologist at the Jewish. It's a very nicely done, simplified frailty score. And this is extremely important later in the age, because we know you're frail, you fall, you break your hip, and that's almost always a terminal event for an elderly. I'm going to skip this. This is just for reference. There is a problem even with these validated metrics. These usually measure the risk at a population level. So it's not as individualized as we want. So it's precision medicine. It's not personalized medicine. All the kind of markers, they capture different aspects of aging. So in the end, we need a composite score, just like the composite genetic score we heard about. And the two tests that I mentioned, they're best associated with frailty and mortality. So if one is really to do something, it's best to do them both. Of course, cost comes into consideration here, and there's this expression of multi-omic approaches, so genomic and proteomic, et cetera, and to get a kind of a composite score. Most of the age calculators require further validation, and there is no consensus about what's best to use. Where does that leave us when there's no consensus? The best next thing is the opinion of an expert. I'm not an expert in the biomarker, so you have to find someone who's an expert there. As we heard from the previous speaker, for genetics, the same thing. You go to an expert and a geneticist. Here, just it's very important, as you say, we need a test to tell us something, so we can do something about it. The epigenetic clocks can be adjusted with measures against inflammation, glycemic control, and immunosenescence, and metabolic biomarkers with the boring stuff, which is smoking, weight management, physical activity, dietary and sleep optimization. And very interestingly, everywhere you look in these biomarkers, these 5 things come out consistently. So that's not news. The problem is all of these are hard to do. Then we're going to talk about imaging biometrics of the brain. So this is a test that we actually now do in Montreal. This is for a patient, young patient, almost my age, heavy drinker. His age is 12 years ahead of him, and a brain age of more than, say 2 years. It's 1.75, more than 2 years associated with 2.6-fold higher chance of mortality, kind of like before your age is supposed to be. There are 7 MRI-based biological ages: heart, liver, fat, spleen, kidney, and pancreas. Only the brain is commercially available. The rest is in the domain of research. Again, this is actually from one of our patients here in Montreal. So I'm going to take a technology pause and do a philosophy detour. We're going to talk about cancer. The most important thing to know about cancer is the capricious nature of cancer. This is a Pulitzer-winning book by Dr. Mukherjee. It's called The Emperor of All Maladies. This is a profound point that is central, in my opinion, to the philosophy of longevity medicine. 40 to 60% of cancer cannot be attributed to modifiable risk factors. Sometimes I tell the patient, well, you have cancer, and a part of that conversation is, oh, but I did everything right. I never smoke, So that's a hard conversation, but there's no causality here. Cancer has no age limit or age cutoff. This is a child in utero. It's an MRI with a large brain mass. So that's a hard image, but I think this is a great image to have in mind because none of our rules and heuristics about cancer applies to that fetus. If they can get it, I can get it. Some common patient beliefs about cancer that it's caused by stress and worry, not necessarily. Environmental pollution, not necessarily. Bad luck, almost a genetic component to it for sure. Most people don't think but behavioral and biological risk factors have a role in it. And the reason why it matters, it prevents people from seeking cancer early detection tests. So one of the biggest screening problems is not really the technology of screening, is how we're explaining it, is how we explain it. So screening does not eliminate cancer risk. And cancers just occur despite perfect screening. The goal should be framed not about prevention. So if somebody comes to me and say, I want a full body MRI so that I don't get cancer, I say, okay, let's do it. And that day I can tell you don't have cancer. And I can tell you with high reliability that in a year, you're not going to die of liver cancer, kidney cancer, but you might have pancreatic cancer in 1 year. So things develop at different rates in the body. Same for breast cancer, slow progression, thyroid cancer, colon cancer, prostate cancer, one of the slowest. The role of fear. And I say this because fear marketing is really important to do or not to do, depending on what you want to do with that marketing. It's been shown that if someone is scared, they might get more screening, but they might actually not get the screening at all. So fear marketing is, of course, frowned upon, but its outcome goes both ways. So probably marketers should know that. And procedure-related fear is a big barrier. I'm claustrophobic. I don't want to have, an MRI. I don't like the radiation. I don't want the needle in my arm, et cetera, et cetera. And the last thing is normal results only provide temporary relief. Usually sometimes after a week, the anxiety is back. So there is this thing as an irreducible minimum of cancer, right? And the reason is it's built into our genome. Without the mutations that cause cancer, we would have never become humans from the fish and the amphibians and the apes, et cetera, et cetera. This has been done in a study. A hypothetical model showed that if you eliminate smoking, obesity, and alcohol in Denmark, you would still have the same number of breast cancer and colorectal cancers. And actually with prostate cancer increasing because now you're living longer. So prostate cancer is just the price for men to live longer. So, so the most important thing is zero cancer is not achievable. Now, a lot of people say, if you don't have a risk factor, your baseline risk is very low, and that is correct. If you don't have any risk factor, what's your baseline risk? It's 1%. 1% is also the risk of each of us dying in a car accident in our life. Now, we accept enormous personal costs and inconvenience for road safety. Imagine how much extra money you pay to get that Volvo with 5-star rating over the BMW, etc. We do, and I don't know, do we do the same for cancer prevention? I have my opinions about that, but that's my opinion. And in Canada, significantly more people die from cancer than from car accidents. Cancer is the leading cause of death in Canada. Car accidents, it's not even in the top 10. So there is a little bit of a cognitive dissonance here about our perception of reality. So this is as opposed to Dr. Mukherjee's book, which says The Emperor of Our Maladies. If you have seen the movie Usual Suspects, he says, the devil's greatest trick was to convince the world that it doesn't exist. My variation of that is the cancer's greatest trick is convincing us that it doesn't happen to us. All right, so we're going to go back to technology. These are a bunch of things that I do almost on a daily basis. for my patients. Easiest cardiovascular disease detection technology. This is decided, this is proven, this is just reality. It's no experimental, no science, just all science. Coronary artery calcium scoring, lots of data about it. Carotid intima media thickness. This is a little bit more new, but also very significant. And then these can be combined with your sugar profile and the lipid profile and the genomics, et cetera, et cetera. So very easy, $500. This depends. I mean, this really takes 3 minutes to do. So we sometimes do it as an add-on for the patients. It can be done with a mobile device, but some people charge $3,000 for this one, whatever the market pays. Next, neurodegenerative detection is now important because 10 years ago, we didn't have a treatment for Alzheimer's disease. Now we do. So 10 years ago, if you knew you were at risk, you couldn't do anything about it. You could kind of solve about it, but not really do anything else. Now we have disease-modifying agents, FDA approved. So it now matters if somebody tells me, hey, you're at high risk for cognitive decline in 5 years. So I get tested, and when the initial signs appear, I go and get my disease-modifying drugs. So some of these are blood-based biomarkers, molecular imaging, and some structural MRI. The best test we have, which is a blood test, and therefore it's a scalable entry point. This is really important because we want something to be simple enough so that a lot of people can have it. It doesn't require a $3 million MRI setup. It's the plasma, P, this and this and that. So that's the best test we have. Next is a nuclear medicine study. It's a tau PET, and this is the strongest predictor of decline. And this is a decisive tool. It's not screening. So you get the blood thing, and if you're at high risk, you get that, and that tells us what to do now. The PET is fairly expensive, which is where the structural MRI and neuroquantification comes in. This is supportive, but the advantage that it has, it's cost effective. It's like $500-600 of extra to a full body MRI. It has the ability to take into account all the neuropsychiatric profile of the patient, the mini-mental state, et cetera, as a clock. And then it adjusts the probability of specific type of neurodegenerative disorders based on the clinical data. Why is this important? Because I myself, if I don't die of a heart attack or car accident or cancer, which I'm planning to do all three, it's probably the neurodegenerative stuff that's going to get me. So this is a best position as a supportive tool in symptomatic patients. I myself am surprised of how useful this is in my patients because we don't have access to the other two tests. We're going to talk about liquid biopsy. In 2016, I heard this term in a radiology conference where they said, guys, this is coming up. This is almost the end of a lot of radiology technologies. It hasn't really materialized like that. This is kind of, they call the multi-cancer early detection. And the basis is simple. You're going to have a solid tumor somewhere. These tumors shed their cells or the breakdown of their cells in form of molecules in the blood, and the technology detects that. The issue with that is most detected tumors, pancreas, ovary, are late stage or recurrent. So this is, I don't want late stage cancer. It's kind of, it's for me, I want early stage actionable. This is the whole body MRI, which is, I'm going to have a quick 5-minute blitz talk about this. It's an established screening tool for high-risk population. Leaf from MRI, both children and adults. They get it yearly. So there's no doubt about its clinical ability to find cancers early. The tool is almost perfect. No radiation, so you can use it in 3-year-old children as long as they can tolerate the exam. It detects a broader range of findings, including aneurysms. It is said to have inherent limitations for colon, thyroid, and breast cancer. Breast cancer, yes, I would debate thyroid and colon with the new protocols. And it is much superior to liquid biopsy for early cancer. I think this is where we need to focus. Cancer detection, a lot of people talk to me about PET-CT. I don't even have an image for this. I dismiss it fairly quickly. It's not recommended, limited sensitivity, lots of false positive rate, radiation exposure, quite expensive. Now, cost effectiveness. Remember I said the money is going to come out of the patient's pocket. Okay, the government probably is not going to pay it. There are programs for high-risk patients, like the Jewish, it's Dr. Christine Wong. So she has her like high-risk breast cancer, the genetics, and the annual MRI. But for the rest of us who have the advantage of not having a genetic abnormality, the money is gonna come from our pocket. There's this Hercules study that's going on right now. This is from the primary investigator was my boss up to a few months ago. Sefi, wonderful guy at Prenuvo. So they're looking into this to see whether the whole body MRI is a cost-effective strategy. So in the absence of that data, and again, up to 48 hours ago, nobody said that this cost-effective or not. This is my early detection tool pick, whole body MRI. This is why I practice it. Remember my financial disclosures too. I think it's definitely the most comprehensive, most cost-effective, and it's multi-system. And here's why: there is no early detection longevity test that can detect an aneurysm, liquid biopsy, genomics, you name it. And if a test cannot tell you whether you have an aneurysm in your head or not, I think it's useless. I go get a clean bill of health, go out, aneurysm ruptures, 40% mortality right away. Okay, so I would argue that it is worth knowing how much money you have in the bank, yes, on a daily basis, and whether you have an aneurysm in your head. Okay, so I think those two have the same value. The same for, do I know if I have early cancer in my body? I actually do. I just scan myself. So is that a question that you need to know the answer to? I would argue yes. These things remain the same. It's the only tool that allows quantification of the. Am I over time? 2 minutes left. Okay, I can wrap it up 2 minutes. It's the only tool that allows quantification of liver fat without an extra step. No more weight, no DEXA, etc. You just do it at the same time. For sarcopenia and frailty assessment, MRI is the gold standard. Nothing else replaces it. It's the only tool that allows simultaneous neuroquantification for brain age. This is so easy that whenever we now do full body MRI, we acquire the data anyway, whether the patient wants it or not. If they want the analysis, we charge them the money for the analysis, but the data is acquired. So, I would know at, say, 2 years ago, the volume of my brain. If I check it in 3 years, we can kind of make deductions based on my cognitive ability. And it's the only tool that allows complete anatomical mapping of the entire body. Aneurysms, we talk about, whether it's intracranial aneurysms or abdominal aorta aneurysm, as well as a bunch of other important anatomical variations that can cause morbidity. It's the only tool that allows validated bone marrow assessment. It's our choice when we look at bone marrow disease, such as myeloma, lots of science on it. And this is something that radiologists don't know. This is something oncologists don't know, probably respirologists don't know. MRI performs as well as a low-dose CT for detection of nodules that are above a certain threshold. 8 millimeter, it's 100% sensitive. It doesn't detect the little 1 millimeter, 2 millimeter ones, so it doesn't create the unnecessary follow-ups and incidentals. It only detects what matters. And here it shows that these two, even for measurement of the volume, it goes very, very close to the CT. All right. The important thing is everything else is going to lead to MRI. If you have a positive liquid biopsy, we have to find the tumor. If you don't find the tumor, you can't treat it. So as the treatment, that's a tumor in the pelvis. So positive liquid biopsy usually ends with an MRI. What a negative test means is that you don't have the cancer or an aneurysm at that moment. Probably no pancreatic cancer in the next 6 months to 9 months, almost 12 months. Definitely no colon cancer. breast cancer, prostate cancer, kidney cancer, that can kill you in 2 to 3 years, because we know they progress slowly, but it is the result expires. So this becomes a lifestyle choice, just like going to the gym. Every once in a while, you go and get your full body MRI. And these, I'm not going to go through it, but it's just there for reference. These are the questions you would ask before choosing any longevity service to, in the wild, wild west. I'm gonna be the kind of the keyword for today, to protect you from, consumer abuse, I guess. All right, thank you very much. Thanks for listening.
Do you have any questions? Yes, no, yeah.
We don't have anything better than that.
Oh, yeah, okay. So the
The average for someone who is an average risk, what would be the ideal age?
We don't have the data for that. The youngest patient that we had is 19, is my son. The second youngest one was 21, just self-initiated. It's impossible to have a cutoff age. Remember that fetus, right? So the complexity of this is because you have to manage risk that is imperceptible, right? That is risk management is very difficult. We assume that children don't get cancer. There's a 50-story cancer center in Texas dedicated to children cancer. You look at that, you change your opinion. So there's no minimum age. 16 and above here in Quebec, patients can make their own choices. Certainly, full body MRI again is used in children of all ages with cancer syndromes. It's very difficult to say. I sometimes say, if you can work for your money, then it's. It's about 40 minutes to 50 minutes. You can take breaks in between. They take you out if you don't want to. Our oldest patient was 73, I think, so it's not impossible to do. We do it at $3,500. Other centers might cost less. Our price is adjusted. The price of the Prenuvo in US dollars, $2,500 without the trip. So, you don't have to go to New York. $2,500 US dollars. We do it a little bit differently. If you go to some other practices, you go get the scan, you go home, you get a report. With us, you go get your scan, then you come and see me, then I sit with you, we go over everything, and there's this big sense-making review and consultation, because getting a paper with a bunch of terms that you can't understand, and you have to go to ChatGPT, and that can cause its own stresses. We also arrange for any downstream follow-ups. You find cancer, you send to surgery, et cetera, et cetera. So, hi.
Hi, thank you for the talk.
Sure.
I think you mentioned that full body MRI is limited for thyroid, colon, and especially breast.
Yes.
I was just wondering why that is the case.
Colon is because most protocols do not use contrast. We use contrast. I'm actually actively looking to see if any of our patients develop colon cancer in the 5 years after they had a negative. My hunch is that it's no, because we do MR colonography sometimes for some of the patients. We do MR of the small bowel routine, but we need contrast for that. So that's the overall thought behind it, because most people don't use contrast. Breast is completely out of the field of view. So joints. To look at breasts, to look at the joints, we need dedicated antenna. We need only see the breast, only see the shoulder or knee at the high resolution. So that is an engineering problem, because once you try to look at the knee, you can't look at the rest of the body. Thyroid, I don't understand why they talk about thyroid. Thyroid cancer is really easy to see on MRI, because probably there are no guidelines about how to report them. It's mainly on ultrasound, probably because of that. Yeah, so go ahead, please.
Go through this with the patient.
Yeah.
Come back. What's the follow-up regarding? So are you saying to them, you recommending to them do this on a yearly basis? And I understand every patient is different, but how does that go? Because let's just say if dollar amount is not an issue for a patient, where do you put the edge to it? Am I doing this every 6 months? Am I doing this 12 months? Where do I gain that?
That's a great question. Doing it every day is a waste of money. Every week is a waste of money. Every month, it's probably the same. There's one organ in the body that does not obey any kind of rules of predictivity, and that's the pancreas. Now, most of the cases of the pancreatic cancer have genetic abnormalities that predispose them. And there was a study at McGill with Dr. Zagopoulos where they looked at, let's say I have an abnormal gene for the pancreas. They scan me today. I don't have pancreatic cancer. I come back in a year. I have inoperable pancreatic cancer. So that's pretty fast. Okay, but we don't know about the speed of progression of pancreatic cancer in patients who don't have that gene. But probably 2 years is a little bit too late just for pancreas. 1 year is probably good for pancreas. Sometimes we actually just do the pancreas in a year and then everything else in 2 years. If you don't have a kidney tumor today, it's very likely to have a stage kidney tumor in 2 years, probably even in 3 years. Same for colon, very predictable progression. Prostate, 100%. Very, like crazy variations happen. Something that appears today and advances, it just explodes in 6 months. Yes, we can't prevent that. But I wouldn't say not longer than 2 years. Head is very different. If the head is clear with no aneurysm, probably in 5 years, nothing's going to happen to it. Okay, so, and that's the conversation. You know, the question is how much money do you have to spend? And unfortunately, the financial component is a reality. And then how comfortable are you with waiting more than 2 years? So the patient's risk attitude builds into this significantly. And I can always tell them, do you eat organic food? And if they say yes, I know they're spending money 40%, 50%, sometimes 100% upmark on something that has no proven benefit behind it. Okay, if somebody, you know what I mean? So those are kind of the markers of your risk attitude. Did I answer the question?
I see a lot of patients with connective tissue disorders, aneurysm, but usually
So in the brain, sequences of the brain and neck for head and neck cancer, brain cancer, and one of them is a non-contrast MR angiogram. Yes, we do. Yeah, so that's covered.
So ideally, we should request whole body MRI for screening for early aneurysms.
Well, the brain is different. I mean, aneurysm there, we can do that at much cheaper. Remember that the longer the MRI is, the more expensive it is. So we can definitely tailor them. And we do have 20-minute full bodies, let's say, for follow-up of myeloma. They're much cheaper than that. But we can develop these protocols like a quick 5-10 minute scan for aneurysm. That's easily doable. And then that's going to be probably $900 or so.
Yeah, okay. Okay, thank
All
you.
right.
Okay,
Thank you very much.
Thank you, Dr. Khashi. So thank you, everybody.
At Ebovir Biotechnology, we're redefining precision medicine through AI-driven genomics and Health Canada and FDA diagnostics. Our private lab integrates digital PCR, whole genome sequencing, and AI-powered screening to detect disease early and guide personalized healthcare. With a Santé Quebec certified lab, proprietary analytics, and a growing clinical research network, we provide fast, accurate, and clinically meaningful results. Our tools provide doctors the insights they need for prevention, targeted treatments, and long-term care planning. We work with healthcare providers across Canada to bring precision medicine into everyday clinical care. At Ebovir, your genome is more than just data. It's a blueprint for lifelong health. Ebovir, precision medicine made personal.
Bienvenue à la clinique CYMED, où la médecine moderne rencontre des soins personnalisés au cœur de Montréal. Chez CYMED, nous croyons que les soins de santé doivent être simples, fluides et centrés sur vous. Qu'il s'agisse d'un bilan de routine ou d'un suivi régulier, nous sommes là pour que chaque visite compte. Notre équipe de médecins de famille expérimentés propose des consultations en personne et virtuelles, conçues pour s'adapter à votre horaire et à votre mode de vie. Pas d'attente interminable, pas de paperasse compliquée, juste des soins rapides et de qualité. Exactement quand et où vous en avez besoin. Pour ceux qui recherchent un soulagement expert de la douleur, CYMED offre aussi des traitements avancés, incluant des injections au genou, des thérapies pour la colonne vertébrale et des programmes personnalisés de gestion de la douleur, délivrés avec précision et attention. Nous sommes également fiers de servir la communauté d'affaires avec des examens médicaux, pré-emploi, des bilans de santé pour cadres et des services complets de bien-être pour employés. Parce qu'à la clinique CYMED, votre santé n'est pas qu'une priorité, c'est notre engagement. Prenez rendez-vous dès aujourd'hui sur www.cymed.ca. Découvrez des soins qui vont plus loin.
Hey, bienvenue à la clinique CYMED. Aujourd'hui, on rencontre notre équipe. Suivez-moi, je vais vous présenter Vi et Jean, nos deux ostéopathes. Vi, on peut te déranger? J'ai une petite question pour toi aujourd'hui.
Vas-y.
Dis-moi, qu'est-ce que ça représente pour toi de travailler chez CYMED?
Pour un ostéopathe, l'avantage, c'est que je peux travailler avec des médecins. Référencement 360 pour un client qui a besoin. Mettons, il vient me voir en ostéo, j'ai des doutes. Je réfère à un médecin, on peut passer un RX, une imagerie, et revient me voir par la suite. Le patient, il s'en sort plus heureux aussi, avec même un problème qui est plus pointilleux qu'on est capable de régler.
Une pratique complète.
Exactement.
Merci.
Bonne journée.
OK, maintenant, on va aller voir Jean. Jean, on peut te déranger? Oui. Donc, j'ai une petite question pour toi. Dis-moi, c'est quoi la place de l'ostéopathie dans une clinique médicale?
Alors, combiner l'ostéopathie ici, c'est obtenir un diagnostic médical avec un médecin et derrière venir nous voir pour obtenir un soulagement et éventuellement une récupération plus active et plus rapide.
Excellent, merci.
De rien.
schedule, but we're welcoming him here on the stage. He will talk to us about AI in healthcare, and he's going to introduce himself.
Okay, thank you. Hi, everyone. My name is Mahdi Hosseini. I'm an assistant professor of computer science at Concordia University. I direct Atlas Analytics Lab. We do the expertise of my lab is about developing the core foundations of AI models, deep learning, computer vision, with focused applications to computational pathology. Our vision is to develop meaningful diagnostic tools for pathologists, prognostics, quantitative analysis of treatment responses, as well as like the biomarker discoveries, et cetera, et cetera. So today, I'd like to introduce my research collaborators. So I have a very strong collaboration with both UDM and McGill University. My colleague, Dr. Vincent Trin, he's a pathologist, staff pathologist at Shuen, also researcher at ERIC. So we have been working together for a past few years. I also collaborate with Dr. Basile Tessier from McGill. We work on the spatial transcriptomics with pathology, so I'm going to walk you that in a few slides from now. And also Dr. David Knapp, who's a biologist. So we have built basically a consortium of a research project that is supported by a company, and they have been investing in my lab. And this is an ongoing research at this point. So allow me to give you a bit of an introduction to pathology. So pathology is the practice of human tissue analysis at the cell level, right? For critical treatment decision support. So these tissues, the specimens are sampled either at the needle biopsy or the resections during the surgery. So what happens that these tissues are sent to the pathology lab, they get prepared by means of preparations. They do, colorization process, it goes through a lot of chemical processes to make it ready for the colorization. Why colorizations? To make a contrast between cellular structures, to understand the morphology of the cells, the tissue microenvironment. And then obviously, once the tissue is ready, they cut it and they put it on the glass slide. It's been more than 150 years as the convention is to put these glass slides under optical microscopy, and you mount different magnification lens to go through high magnification. Sometimes it's like quarter of micron per pixel resolution, and then they can investigate, diagnose the cellular structures, what's going on, and so on and so forth. So digital pathology is the digitization process of the optical microscopy. The scanners are done by the whole slide image scanners. And at the end of the day, you end up with a larger scale, or we call it the gigapixel pathology images. We call them whole slide images. And you can hover over, similar to optical microscopy, in a virtual mode. You can hover over the tissue, zoom in, zoom out, and then the pathologists, they do their diagnosis on the monitors, on the computer monitors. The guts of the scanner is very similar to the optical microscopy. So what you're seeing here, allow me to activate my laser point here. So you mount basically the tissue here at the stage. The stage is controlled by the hardware device. So this is the light condenser. Tissue, obviously, it's a transparent component. So the condenser creates the light, the parallel light. It passes through the tissue, and then there's the objective lens and the tube lens. That's how the Galileo concept is, like to magnify the tissue. And then at the end of the day, you have a camera, and the camera observes a limited field of view of the tissue. So because this is a high magnification, and what happens in the whole slide image scanning is that because it perceives a limited field of view of the tissue, then they do a raster scan They scan one strip at a time, and then once all these strips are ready, they stitch it together, and we build whole slide images in a pyramid form to be able to emulate virtual microscopy, to zoom in, to zoom out, and observe in different magnifications to see different morphologies in macro and micro scale. Okay. So case in point, this is a nanozoomer scanner from Hamamatsu. It is capable of, this nanozoomer 360 is capable of digitizing more than 1,000 slides in the duration of 12 hours, 14 to 14 hours. And obviously there's a technicians is involved to to set up all these cassettes of the slides. To set up this slide, the setup requires a lot of attentions and so on. So the AI basically kicks in. That's the vision that basically, the AI is when you have a digitized workflow for your pathology. Most of the pathology lab in the world, even at this point, more than 90% of the pathology labs are still are the conventional labs. They haven't fully digitized because the workload, the sheer volume of these data are gigapixels. Like you imagine, you keep mounting thousands of slides on daily basis, and then if you start accumulating them, you end up an order of petabytes over a yearly basis. So you need a very, very strong hardware infrastructure to be able to make the digital pathology department up and running. But let's say if a pathology lab has been digitized, such as, Shuen is one of those rare hospitals that has been fully digitized their clinical pathology. Then it integrates the digitization in the clinical pathology. So you have an image management system that handles these images, tries to basically provide the service to all the pathologists to perform their diagnostics on a routine basis. So the process basically is that the patient gets admitted to the hospital. They take the sample, pathology lab prepares the tissue, then it gets scanned, and then there's an image management system that manages all these digital records. It gets communicated to the pathologist. They do on a routine diagnostic on a daily basis. They sign out the cases. And then, for the sign outs, there are standards that standard reports. They call the synoptic reports that follows the CAP standard. And then once the synoptic report is ready, it gets passed to the follow-up treatments, including the oncologist, in case that there's a requirement to follow up. Well, obviously, every one of these steps have their own barriers. Like from the admission of the patient all the way to the sign out, there's a lot of barriers. And every one of these barriers, means challenges, so opportunities to that the AI can kick in and automate the process. So in all, in a high-level perspective, the computer-aided diagnostic systems are envisioned to help pre-analytical, analytical, and post-analytical phases. Analytical would entail cancer diagnostics, classifications, segmentation on the image level, prognosis, and even treatment response, predictions. The post-analytical are the ones that the natural language, the LLMs, ChatGPT, for example, that, once you pass the slide, you want to assist the pathologist in signing out the cases. So that's the vision that's the AI would help in the long run. So one example of the computational pathology is basically the science of in taking these digital images, bringing the AI models and be able to process them and develop these computer-aided diagnosis softwares. In order to do that, because the slides are gigapixel images, we chop them into small pieces or mosaics. We call them patches, tiles. And every one of these tiles are in the order of a very similar resolution that you take from your cell phone, 1000 by 1000 pixel. So every one of these corresponds to certain information. You pass it to the AI model. We call them the embedding process. And then once you process all of these tiles or patches, you aggregate them to come up with a high-level understanding of the slide, the pathology slide. And then the AI can predict, whether this is benign, cancerous, and even if it's cancerous, what kind of cancer, and so on and so forth. Tool is highly efficient. Efficient is one of the keys. I'll actually just, because I have 2 minutes, would like to actually pass into the next coming 2 slides or 3 slides. One of the other tools that we have developed is the AI models that, how they actually digest these images and provides cancer understanding on the tissue level. So different AIs sees images differently, and the ones that they are similar to the way that the pathologists diagnose on the tissue is the raster scanning. So we have some AI models that mimics that behavior. And in fact, when the diagnostic results comes in, it's similar to what the pathologists do in reality. And using that information, you can actually understand the heterogeneity of the cancer environment. Case in point is that we have taken our AI model that is done on the pancreas tissue. You're looking at the PDAC. And there are areas that are cancerous. This area is annotated by the pathologist that, the left side is highly cancer, it's invaded. And on the left side, it's cancerous, but it's fighting those. So the lymphocytes are still fighting those areas. And then we pass this tissue to spatial transcriptomics. So this is a new device that on its spatial level, it provides the genomic information of the cellular structures. And then what you can do with the spatial transcriptomics is that you can understand literally basically provides you the signatures of the genomes distributed along the tissue. And then what are we showing that, because this is a very costly approach, we're showing that you can only take the H&E, the slide, the tissue, and provide, using our AI models, you can provide a meaningful results that mimics similar to the spatial transcriptomics behavior. So instead of actually following that very costly routine, you can intake just a normal slide, and the AI can actually provide more the heterogeneity of the cancer environment. And this is very important because you can understand what's going on in the tissue microenvironment. You can entail it, you can understand the mechanism of the cancer, and then using that, you can follow up with more understanding, such as biomarker discoveries and follow-up treatments in future. So all in all, my lab is really to develop these efficient tools of AIs that downstream task to different applications in pathology, from clinical diagnostics, vision languages, you can right now with ChatGPT, you pull up, you pass an image, you narrate, say, what do you see in this image? And gives you a lot of responses, right? The same concept basically follows in the pathology. Treatment response analysis, when patients, two patients following the same cancer, it doesn't mean that they're going to respond to the same drug the same. So, and why is that? Well, the AI can help to explain the environment of the cancer, the complexity of the cancer, and based on that, you can have personalized medicine. And that's it. Yeah, thank you.
So, any questions for Dr. Hosseini?
Yes. Yes. Yes, the question is that how do we relate this to longevity, because this is the focus of this seminar. Yes, well, at the end of the day, these are all about the genomics, right? So as long as you can scan these genomes and be able to comprehend through the AI, you can provide basically the interactions, the mechanisms that it's happening on the tissue level. And this leads to a personalized medicine. And perhaps for longevity, like, it can explain why people are aging. And then, if we call the aging as another variation of like a disease, then it's the same concept at the end of the day. Like, what are the corresponding biomarkers, why that's the case, and then what needs to be developed to, slow that process down. I hope that answers the question. Yeah. No worries. Yeah, so I think this the question is like, other than pathology, if there are other samples are used, like such as blood samples, right? So these all are entails under the umbrella of multimodality, like, data analysis. So pathology, imagine like, you have a pathology slide. On top of that, you have the radiology scan, follow-up treatments, right? Now, the history of the patients, blood samples. So these are all in the context of multimodality data, which is a big hype in the AI. So you can intake all of these information, enrich your decision-making algorithms for sure. Yeah.
So the AI technology that you're developing, I'm curious about the explanation of the cancer environment. So the technology that you're developing, is it being used to uncover new types of environments, or is it working with like the knowledge of existing environments?
Yeah, it's more probably the latter cases. So I'll give you one example. So still there's a debate between the pathologists, like, when they study the tumor, these fibroblasts, surround the tumor, literally basically blockades the tumor from the immune cells. So the question why that's the case and how that is done, it's something that, AI can help definitely kick in and try to provide much better insight to those processes. Does that answers? Yeah. Yeah. Yes. So the question is, how do we prepare for the variations between different facilities? I'm assuming you're referring to the pathology labs. Yes. Well, different facilities or different pathology labs, as I was saying, like they follow. Obviously, there's a standardized protocol. The Dr. Hazrati can much better comment on it. She's a pathologist. But what happens is that, when you are taking, for example, the hematoxylin and eosin process to stain these tissues, there's a step-by-step protocol that you need to dye the, to tissue certain amount of seconds, and then you take it out and take it to the other chemical compound. Well, what happens is that if you delay even fractions of a second or a second, the tissue is going to absorb differently. So your tissue is going to look different under the microscope. So that entails the diversity or variations of tissue stainings. I'll add additional complexity, which is the scanners, adds more variations because sensory calibrations from one vendor to another is different. So at the end of the day, you're looking at a variety of distributions. The AI needs to be generalized on those distributions. So it's called the out of distribution problem, the AI, in the context of the AI. Yeah. Okay. Yeah. Thank you.
Okay, so we'll take 2 minutes pause while we switch to the next speaker. let's get back. Our next speaker is Racha Najmeh, registered dietitian. Racha is a member of the Ordre des diététiciens nutritionist de Quebec with over 15 years of experience in clinical nutrition. Her work focuses on weight optimization, the nutritional management of metabolic diseases, and dietary approaches for conditions such as irritable bowel syndrome. She's known for her patient-centered approach and her emphasis on sustainable, practical dietary changes. Today, Racha will speak about the relationship between inflammation, insulin, and aging, and how nutrition plays a central role in supporting long-term health and longevity.
Thank you. Thank you for the introduction. Thank you, everyone. I'm very happy to be speaking with such great speakers tonight, and thank you for being here as well. When Shua asked me to present something, anything related to longevity, it was actually very difficult to pick a topic because there's just so much to talk about. But then I decided that this topic would be very relevant because there's so much information, but also so much misinformation that's circulating, especially about inflammation, and that it can be hard clinically to measure, and it's not something that a patient gets diagnosed with chronic inflammation. So I thought it'd be interesting to look at how inflammation and insulin can work together to, let's say, they come with longevity, and how they can affect many other diseases. They have been linked to many other diseases. And actually, this is something that nutrition has been proven to help change and improve. Like Dr. Franceschi, he came up with the word health span, and I think it was also used so many times today in the presentation. And obviously the goal when we speak about longevity, it's not just adding years, but also adding quality of life to the years. So I hope this will be interesting today, and we will take a look at inflammation and the causes, insulin resistance and the prevalence, the vicious cycle between insulin resistance and inflammation, the impact on aging, and then the fun part, nutrition as a longevity tool. So what is chronic inflammation? We all know that chronic inflammation is low-grade, persistent immune response that is not triggered by an infection. It damages tissues over time, and it underlies many non-communicable diseases like cardiovascular disease, type 2 diabetes, cancer, autoimmune, and age-related cognitive decline. There's even studies that show that it's implicated in mental health, including depression, schizophrenia, and bipolar disease. The word inflammaging, we come across this term more and more. It was coined by Dr. Claudio Franceschi, and again, it refers to the chronic, sterile, low-grade inflammatory state that develops with age. It occurs without infection, and it's driven by the overstimulation of our innate immune system. So what causes this low-grade chronic inflammation? Accumulated cellular damage over time, declining ability of immune cells to regulate inflammation, chronic exposures to stressors, environmental, metabolic, lifestyle stressors, and the reduced efficiency in clearing damaged cells and molecules. So insulin resistance. Insulin resistance happens when our pancreas is producing insulin normally, but our cells are not responding to the insulin properly. And what happens is it leads to elevated blood glucose because the pancreas secretes more insulin because the cells are not taking up the glucose. And the end result is a compensatory hyperinsulinemia. And with time, high blood sugar, weight gain, prediabetes, and maybe eventually type 2 diabetes. So insulin resistant as a biomarker of ill health and reduced lifespan. Insulin resistance is associated with type 2 diabetes, which reduces life expectancy in older adults. Age-related insulin resistance is implicated in the pathogenesis of several high prevalent disorders like atherosclerotic cardiovascular disease, some cancers, dementia, and frailty. So prevalence of insulin resistance, what we know is that it's increasing. It has increased over the past 2 decades. It increased by approximately 14% in the last 20 years, and similarly, insulin resistance and hyperinsulinemia both increase similarly. It has a higher prevalence in males, non-Hispanic Black, Hispanics, lower educational level, and lower family income. Insulin resistance in Canada, there is no data that measures the prevalence of insulin resistance, but we know that more than 25% of the older population, 65 years and older, have diabetes, and much larger percentage suffer from prediabetes insulin resistance, which often goes undiagnosed. So insulin resistance and age. Insulin resistance that comes with age is driven by, obviously, the increase in visceral fat, reduced physical activity, and also a decline in muscle mass, sarcopenia. We lose 3 to 5% of our muscle mass every decade as of 30 years old, and obviously with menopause, females experience more of a decline or drop in muscle mass. So all these factors can affect insulin resistance and how our muscles and adipose tissues take up insulin. So now what's the link between inflammation and insulin resistance? So chronic inflammation, they looked at insulin resistance and inflammation. And when they tried to understand why these muscle cells, these adipocytes, are not taking up the insulin properly, they found out that the problem begins in the adipose tissues when there's metabolic and mechanical stress in the adipocytes that is causing these cells to produce interleukin 6, tumor necrosis factor alpha, and cytokines. And these cytokines are interfering with the ability of cells to respond to insulin, causing insulin resistance, higher blood sugar, and it's a vicious cycle. What's the impact of inflammation and insulin resistance on aging? It can drive metabolic syndrome. It can increase cardiovascular and cognitive decline, and it can reduce resilience and repair capacity. Yes? Oh. Better. Okay, and now the fun part, nutrition as a longevity tool. So we know that diet directly influences inflammation and insulin resistance. Dr. Shuen here maybe can correct me if I'm wrong, but when I looked up the genetic component and how much genetics affect our predisposition for insulin resistance and prediabetes, some studies were saying 20% and others were saying 40%. So it seems like 20 to 40% of our predisposition, our genetics, are responsible for this insulin resistance. But also what we know is that diet can directly influence inflammation and insulin resistance, both directly and indirectly. So let's look at some of the evidence-based dietary patterns that improve metabolic health. I'm sure everybody in the room has heard about the Mediterranean diet. It's not something new. You've all heard about it, but it's one of the most one of the diets that has most been proven to work with insulin sensitivity and inflammation, help reduce inflammation and insulin resistance. So what is the Mediterranean diet? The Mediterranean diet is a diet that's based on fruits, vegetables, legumes, whole grains, olive oil, nuts, seeds, more fish, less red meats, and obviously, as you can see, minimally processed food. And unfortunately, processed food in the Western world can consist or can constitute up to 40% of our daily diet. So the benefits of the Mediterranean diet: lower inflammation and improved insulin sensitivity. There are other foods that have been studied for their anti-inflammatory properties. As I think everyone knows, the more carotenoids, the more colorful your food is, the pigment that gives the food their color, they are also very powerful antioxidants that help us avoid inflammation. Fatty acids, so omega-3s, nuts, seeds, olive oil, and some compounds in turmeric, ginger, and garlic. Foods that improve insulin sensitivity: high fiber foods, so legumes, whole grains, vegetables. A little word about fiber. Fiber is the part of the plant that we eat, and it travels through our digestive system, and we flush it out. So if we're flushing it out, why is it so good for us? It's so good for us because as it travels through our digestive tract, first up in the stomach, it's going to absorb water and it's going to create bulk. So you're going to feel full for longer. It's going to provide that feeling of satiety. And then as it moves undigested, as these fibers that do not get digested and absorbed, as they move along our intestines and reach the colon, they provide food for our microbiome, for the good bacteria. And they also act as a sponge, helping us help bind to some of the glucose in our meal and even some of the cholesterol, and help us with cholesterol and glucose control. So fiber is very, very important. The best source of fiber, the food category that has the most fiber per calorie is the legumineuses, or the beans, so peas, chickpeas, soybeans, garbanzo beans, lentils, all the bean group. I think we don't eat enough of this group here in Canada, and sometimes it can be intimidating to eat these foods, or they take a lot of time if we want to make them from the dry, but something definitely to add more of in our diet. Okay, sorry, I have a... This is not supposed to be here. Oops. Okay, foods that improve insulin sensitivity. Also, it has been shown that lower glycemic index foods have a much lower impact on this postprandial glucose spike, and they help us avoid, let's say, insulin resistance. So, what is the glycemic index? What is the glycemic index? Glycemic index is a measure given to individual foods, and they look at how fast they raise our blood sugar after we consume them. And here, what I find interesting, I added some random examples from each food group. And what's interesting is that sometimes the same food, for example, potatoes, if we cook them and cool them, some of that starch becomes resistant, and their glycemic index becomes lower. Whereas, for example, you'll see here, a hot potato has a much higher glycemic index than boiled and cooled potato. Also, it seems in the category of breads, sprouted bread, sprouted grain bread has the lowest glycemic index. Nowadays, it's so easy to find the sprouted breads in the supermarket. You can find it in the frozen section or in the fresh bread section. A gentleman asked me, "What about the morning? How can we increase the fiber in the morning?" From the cereals group, it seems that the steel cut oats and oat bran, obviously, have a lower glycemic index than quick oats, muesli, and granola. And obviously, the more we process our grains and cereals, the higher the glycemic index. Here I have just a few examples, but I'd also like to speak about foods that we consume a lot of, like rice. Rice and pasta can be very high glycemic index food, whereas there's lots of healthier, better alternatives that have more fiber and a lower glycemic index, like barley, bulgur, quinoa, and even brown rice. Now, again, in the foods that have been shown to improve insulin sensitivity, lean and plant-based proteins. Also in the Western world, we consume so much meat and even chicken. So maybe we should try to incorporate more plant-based proteins or mix. If you don't want to give away your animal protein, maybe think a bit less and adding some lentils, beans, peas, chickpeas, etc. Fermented foods also seem to have a positive impact on insulin sensitivity, and these foods include yogurt, kefir, even some beverages like kombucha, kimchi, sauerkraut, tempeh, and even fermented grains. Now, what are the foods to limit? Because they increase inflammation and insulin resistance. Number one on the list, ultra-processed food. So this includes the processed meats, the hot dogs, the sausages, the pepperoni, and all these processed meats. But again, anything that's packaged like cookies, cereal bars, which we think are healthy, donuts, fries, etc. Sugary beverages. I feel this is something that everybody knows already. Refined carbs like rice and pasta and bread. A lot of the bread that we buy, unfortunately, is very heavily processed, and sometimes we think we're making a good choice because we're buying a higher fiber kind of bread, but because it is so ultra processed, even with the fiber, it still has a high glycemic index. So less refined foods, more fresh, and also excess saturated and trans fats. Other evidence-based eating patterns or diets that have been proven to help with longevity and improve insulin resistance and inflammation, we'll find time-restricted eating, or famously known as intermittent fasting. It seems that intermittent fasting can have a lot of benefits when it comes to insulin sensitivity and inflammation. Let's note, however, that intermittent fasting is not for everyone, and the research shows that males tend to benefit more than females with intermittent fasting or time-restricted eating patterns. Balanced macronutrients, so also what can help remove some of the load, from our pancreas in terms of insulin production, is having a protein or a balanced for our meal to be balanced. So having a complex carbohydrate, a source of carbs with a lot of fiber, minimally processed like quinoa, even brown rice, any whole grain like barley, and also having a source of protein. The protein and the fiber in our meal is going to help us slow down the glycemic response. And this is obviously favorable circumstances for our pancreas and our cells to process the glucose that we're absorbing from our meal. This is the new Canada plate or guide, food guide. They released it recently. Recently, it's been a few years. And they recommend that half of our plate consists of fruits and vegetables, mainly vegetables, and the other half, quarter protein and complex carbohydrates. Hydration also supports metabolic function. We forget that water is a nutrient, and we need to stay hydrated. Obviously, other lifestyle considerations, like Dr. Rafatzand mentioned in his presentation, these come back almost any time where we're talking about lifestyle and health. So quality of sleep, movement, and stress management. Sometimes controllable, sometimes not controllable. Other lifestyle considerations, so exercise. I know that Dr. Sairam is going to speak more about the muscle mass and investing in our muscle mass. Everyone asks, what is the minimum or what is the recommendation for exercise? The recommendation is approximately an hour 3 times a week, or 150 minutes per week of moderate intensity exercise. Or shorter, 75 minutes per week of vigorous exercise, and always combined with a little bit of strength or resistance training to maintain that muscle mass and counter the effect of muscle loss with the years. Practical tips. So obviously, we always want small, sustainable changes. When I know when the patients come to see me, sometimes they want a meal plan and they want to drastically change their diet because the doctor told them that they have so and so condition, metabolic disease, or high cholesterol, and they're afraid. But it's always the little changes that we can maintain. These are the ones that will have the biggest impact on our health. The scale, obviously, visceral fat and weight is a big driver when it comes to insulin resistance. So maintaining a healthy weight is one of the best preventative measures we can take. But sometimes focusing on the scale can be harmful because the scale is not the only measure of your success. And sometimes you can be losing fat but gaining muscle. So sometimes the scale can be harmful because this can be discouraging, and the patient will forget all the beneficial positive changes that they brought to their diet and go back to eating like before. So even if the weight doesn't move, bringing these changes to your diet and lifestyle will have an impact on your health. And labels, I think we have, we're lucky here in Canada. Our labels and the regulations are very easy to read. For example, in Europe, all the labels are all per 100 grams. So sometimes, like, what's 100 grams? How much is that in my rice or my pasta? So the labels here are a great tool. They're very relatable, and they just introduced the little warnings. Even my little kids, they look and they see, oh, mom, this has a lot of sat fats. So it's a good tool that we should all be using. And before I take your questions, I have a few questions for you, just to reflect on the way you're eating right now. How much of the food I eat is processed, and how much of the food I'm eating is fresh food? How can I replace my favorite processed foods with foods I enjoy? What can replace my sausages or my cold cuts? Are my meals balanced? Do I have protein at every meal? Do I have high fiber carbs or complex carbs at every meal? Do I eat fermented food? How can I add fiber to my diet? And am I reaching the recommendations for physical activity? And what about sleep? So, conclusions. Your diet directly influences insulin sensitivity and inflammation. A healthy Mediterranean diet, rich in lean sources of protein, omega-3s, fiber, has protective effects. And obviously, let's not forget about the lifestyle. So the stress, the sleep, the physical activity. What can we do to minimize these and live better? So thank you, and hope you have some questions for me. Yes. Good question, because if someone's considering taking supplements like protein supplements, are they considered processed foods? Definitely, because a lot of these, and it depends, definitely, and it depends on the supplement. For example, if you ask me, it depends which kind of protein for which purpose. For example, are you trying to gain muscle, or is it just because you don't have enough protein in your diet or in your meal? There are some kinds of proteins that are very minimally processed. For example, if you go on UPIC, which is a Canadian company, I am not paid to advertise, but just as an example, and because it's local, I love to promote it to my clients. You can just buy pea protein powder, and the only ingredient is ground peas. And this is what we added this morning to our crepes. We made crepes. We didn't add any sugar, whole wheat flour, and about a quarter cup of this pea protein. So there are some good, some ways to find minimally processed protein powders, but a lot of the ones you buy at the gyms, for example, they're going to have sucralose, aspartame, acesulfamide K, and emulsifiers and other ingredients. Question? Yes? Thank you. My opinion about the carnivore diet. So the carnivore diet, or the paleo diet, is a diet that's high in saturated fat, sodium, and definitely lacking fiber. So in the short term, it can definitely, they can get the results if they are looking for the muscle mass for bulking, but it's definitely not a sustainable diet, and they're missing a lot on the the beneficial fiber that will promote gut health and feed the microbiome. Yes? Yes. Oh, yeah. Yeah. My opinion about the fiber supplements that you add to the water. Psyllium fiber, for example, is an example of these this kind of fiber, and I guess everybody has heard or used Metamucil, which is psyllium. Psyllium is honestly maybe the gold standard of fibers. So in this case, definitely, if you need a boost or if you're looking for an easy way to add fiber to your diet, psyllium husk or psyllium fiber is the gold standard. It creates like a gel. There's two types of fiber, soluble and insoluble. And the soluble fiber in the psyllium, which actually maybe the most common way to consume it is through these supplements, is very beneficial. So definitely in that case. Yes.
So for bread and the glycemic index, if you wanna like choose like regular bread, or it's not really regular or processed, and then sourdough and then sprouted bread, which one would you choose the best?
Which one would I choose? Honestly, it depends. Sourdough, it seems, there's white sourdough and there is whole wheat sourdough. Whole wheat sourdough has a lower glycemic index. Sprouted bread, for some reason, scores the highest for the glycemic index, or I should say the lowest. It is the best, let's say, sprouted bread. Back like a few years ago, the only brand was Ezekiel. I don't know if any of you is familiar with it, and you would find it in the frozen section of the supermarket, because when we sprout a grain, it gets spoiled much faster. The bacteria can grow faster. But now if you go at Costco, you'll find a whole section, or at least 2-3 choices of sprouted grain. So I would say either or. If you are intolerant to gluten, if you have irritable bowel syndrome, then sourdough has less FODMAPs, so it has less gluten because of the way it is fermented. So if you have IBS or if you have gluten intolerance, I would go for the sourdough. Otherwise, I'd go for the sprouted one. Thank you.
Thank you. So we'll go again for 2 minutes break to change the speakers. And to welcome our last but not least speaker. So just before introducing Dr. Charith Sairam, there is small housekeeping. So we'll be passing post-it around. Please write your name. We'll have a raffle. We have 3 winners they're gonna win tonight. We have free genetic testing from Ebovir. So after the talk, we collect the small post-it. Do you have free MRIs also tonight? Okay. No. Yeah. No. Yeah. And yeah. 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 Okay. Okay. Deal. So okay. So we have 4 winners tonight, and we have a nice dinner. So after the talk, we'll go to the 4th floor. We'll pick up the winners. We'll have lunch. We'll have fun after this nice day. Okay. So let's introduce Dr. Charith Sairam. So he's an assistant professor of medicine at McGill University and a consultant general internist at Shuen Hospital. Today he will be speaking about muscle as the organ of longevity and the role of muscle mass as a long-term investment in health.
Thank you, Dr. Schwa. It's a real honor for me to be with you all today, and there's some really fantastic talks today. I hope you all took some great notes and got some good tips. So a little bit about myself. I've been practicing medicine now for almost 14 years as attending staff at the MUHC. And throughout those 14 years as an attending, I've been practicing what's called rescue medicine. What does that mean? You come in with a heart attack, I fix you. I can prevent you from dying that day. You come in with kidney failure, I saw somebody this week, new kidney failure. I fix that problem today by dialysis. Or you come in with a new diagnosis of pancreatic cancer because you came in with jaundice. And then we start the treatment that day. But what's gotten me really passionate about longevity is that now I think we're entering the phase of preventive medicine. And that's where previous practice of medicine has really, I think, failed in some sense. Just to give you some ideas, in the last 30 years, we have decreased the mortality of cardiovascular disease. I would say that. But now people are living longer with the disease. So they're not living better, right? We have decreased potentially the mortality of cancer, not stage 4 cancer, unfortunately. And we have new therapies that are always coming out. So they're living longer with those disease and with the disability. So that's kind of the background of the landscape of medicine nowadays. And so this week, I see in general internal medicine such a varied field. So I see basically all the pathologies. I get to interact with my good friends, Dr. Kashi, Dr. Fadi, the radiologist, the pathologist, the chemotherapy doctors. So I'm at the kind of center of a lot of these pathologies, and it gives me a lot of insight into what's happening in people's lives. So today I'm going to make the argument that not requiring any fancy testing or advanced diagnostics, but something so simple, that skeletal muscle is the largest endocrine organ in the body. So what is an endocrine organ? It's your thyroid, it's your pancreas, it's your adrenals. And I'll make the argument that skeletal muscle, it's not just about vanity, about looking good like Arnold Schwarzenegger or something like that, but having healthy skeletal muscle and a very active lifestyle prevents those diseases that we're going to talk about a little bit. And what are the diseases that all my colleagues all mention? Number one, if you don't pass away from an accident or a childhood illness, at some point in your life, as you age, you will get metabolic disease, diabetes, particularly, right, which causes so many downstream effects. In that metabolic category is obesity, and there's cardiovascular disease, so heart attacks and strokes. And the third thing, we call them the four horsemen, basically, metabolic, cardiovascular. Number 3 is neurodegenerative diseases. So like Dr. Kashi was explaining, Parkinson's disease, Alzheimer's, dementia. And then finally, the big C. The big C is not Dr. Charith. It's cancer, okay? Cancer. So those are the things that can be potentially prevented with a healthy lifestyle. So that's why I came up with this idea of building your pension plan, your retirement plan, right, for when you age. So muscle is the organ of longevity. So it was already previously mentioned. I'm not going to reiterate it too much, but longevity has 5 buckets. Number 1, exercise, that we're going to focus on today. And within exercise, there's a few categories. There's stability, right? So if you trip, are you able to maintain that, not fall down and break your hip, right? That's stability. Number 2 is aerobic capacity, right? It's particularly what we call zone 2. Zone 2 means 60 to 70% of your maximum heart rate. We can go over the calculation later if you're interested. And then finally, I'll make the argument about strength. So particularly grip strength, for instance, is correlated well with longevity. People who don't have good grip strength, for instance, it's a surrogate marker that your whole body is weak. And then finally, what we call VO2 max, which is how fast can you go and how hard can you go for a period of time. And that dictates how efficient your mitochondria are in your body and how good your heart is. The next bucket that Dr. Racha talked about is nutrition. I'm not going to belabor the point of nutrition. I think nutrition is very high yield. The only point I'm going to try to make for you all, the only thing I have to say about nutrition is that in the West, we don't have a problem of malnutrition because people here are overnourished, I would say, right? They have our food is so tasty, so cheap, right? Yeah. I mean, I'm talking about processed food, right? It's so cheap, and it's so accessible, it's so available, right? Nobody here doesn't have food, right? So they're so overnourished, and then you get all these other diseases, right? So the only thing I have to say about nutrition is you should know what your intake is, your output is, so that you don't go up or down in weight, essentially. So you should have an isocaloric diet or a hypocaloric diet, potentially. And then finally, also was mentioned, sleep is really important. I'm not going to go into the details of sleep, but sleep is very important because we always thought that sleep was a useless activity from an evolutionary point of view. Many scientists never figured out, like, why do we sleep? But now we know that sleep clears, there's lymph in the brain, and we clear all these cells, all these senescent cells, basically. So it's very important, and how it affects mortality also, good sleep. There's the emotional health aspect. I think that's really important in terms of quality of life, how you deal with stress, trauma, and emotional regulation. And then finally, there's exogenous molecules. So whether you're on hormone replacement, drugs, medications, supplements, that falls in that bucket. I think the first 3 things are the high yield thing. If you have your diet in place, you have your physical activity in place and your sleep in place, you've covered 80% of the bases, right? The rest is extra. So moving on. So here's a little diagram. So VO2 max is your heart capacity. So I use the analogy of a car. So this is a high-end supercar. You have a very big engine, right? That's your heart and how you use that oxygen. And then you also have to consider the chassis, the body of the car. Can it handle that, right? So you have like a rigid body, a strong body. So a good heart and a strong body together makes for a very good car, for instance, right? All right, here's a question for you all. For those of you who don't know me, so I'm going to ask you a question. How old do you think I am? Let's go with the first option. I won't take any offense. Do you think I'm 25 years old? Put your hands up if you think I'm 25. Somebody's saying I'm 20, my biological age. We're not talking about my chronological age. 1 for 25. Who thinks I'm 45 years old? Put your hands up. Good. 30 years old. 40. 40. Good. 50. Nobody for 50. What about 35? Okay. So we got a little bit of everything. We're going to come back to this after. We'll do a little calculation and something you can do to figure out. Very easy. You don't need a lot of fancy tests for this, but we can look at that. So what is skeletal muscle? You have 3 types of muscle in your body. You have your skeletal muscle that you can voluntarily contract. You have your smooth muscle. For smooth muscles, like the muscles in your airways, in your lungs, in your digestive tract. Okay, you don't have voluntary control over that necessarily. And then you have your cardiac muscle, right? Even there, our capacity to increase your cardiac muscle is very limited, actually, even through training. So muscle makes up about 40% of the body, and it's the only organ you have voluntary control over. And the explanation I would like to make is that skeletal muscle is that metabolic suitcase or the control center. That's where you use all the carbohydrates you take, all the amino acids from protein, and all the fatty acids. And what's great about skeletal muscle, it releases a lot of interesting molecules called myokines. So this is new research in the last decade. Myokines are almost like hormones, you could say. So the act of stressing muscle or bone releases these myokines, and they go and do all kinds of wonderful things, particularly in the brain. In the brain, it goes and acts on different systems, and they release different kinds of molecules that are very important for things like preventing dementia. And one of those molecules is called BDNF, brain-derived neurotrophic factor, and super important for a healthy brain. So modern medicine really does focus a lot on what we have to lose. So obesity is an epidemic. By 2040, we're looking at 50% of the population, like clinically obese. That's a big problem. So yes, we can lose all that body fat, and we can have all these drugs like GLP-1s. Everybody's on Wegovy, Ozempic, or some kind of other designer drug. But I'm just going to make an argument that training and eating a proper diet is better than a GLP-1 in some ways. So this is the analogy. Muscle is your metabolic suitcase. So when you're not active, your suitcase is full. It's full of what we call glycogen, fat, right? It does store some, right? There's what we call intramuscular adipose tissue. And what happens, right? So if you start eating a lot, it has to go somewhere, right? And then every time you do some activity, you empty those stores. So your body can store about 400 grams of glycogen per day. That's in your liver and your skeletal muscle, right? And you can then empty that out. And then when you eat, it'll get refilled, right? And not go into dangerous places. So it's a sink, the muscle. It's a metabolic sink. So here's some facts. Strength training, for instance, 30 to 60 minutes a week. That's it. 30 to 60 minutes a week, up to 20% lower risk of all-cause mortality. It's not a lot. Okay. This is the data on having a good heart, right? Survival of the fittest, basically what we call the VO2 max. So we know that if you go from below average, you go from couch potato to above average for your age group, I can reduce your all-cause mortality significantly. Significantly. We're looking almost at a 5x decrease in mortality, right? If you go from low to high. Oh, that's impressive. If you think about it, if I were to put all the benefits of exercise and physical activity into and package it into a pill, each and every one of you would be buying that pill, right? But it's so easily available to you right now, right? So there's that. And then there's another solution that people don't consider. And more research is coming out that looks at what we call, you probably hear it in different term, you call it high intensity interval training, but this is another thing that we call an exercise snack. It's called vigorous intermittent lifestyle activity. You're at the hospital, you're at your workplace, you decide, I'm going to use the stairs every single time. I sprint up the stairs. If you have children, you're chasing them, you're carrying heavy grocery bags. Interesting, right? So the data shows that 3 to 4 bursts of 1 minute activity. 1 minute, that's it. Getting your heart rate up. Maybe close to your maximum heart rate, which is 220 minus your age. That's it. It's an easy calculation. 40% reduction in all-cause mortality and 50% reduction in cardiovascular death. Isn't that impressive? There's not much there. You know. All right, everybody get up now. I want everybody up now. We've been sitting the whole afternoon. All right. We're going to do some Vilpa right now. This is my idea. Get everybody moving. So we're going to do 20 air squats, okay? Do them as easy as, you know, be careful if you're not used to doing this, in 40 seconds. So I'm going to start the timer. Everybody's ready? 1 second. Just get some room, okay? Everybody knows how to do an air squat? Basically like that. Good. Knee bend. Yeah, 90 degrees if you can. As much as you can, whatever you're able to do. Okay, let me get the timer on, and then we're going to go. Okay, start. 20. See somebody doing pistol squats here. Whoa, this is exciting. One-legged. Good. All right, we got 15 more seconds. Keep going. Did you hit 20 yet? Let's go down. Good. All right, 5 more seconds. Excellent. Okay, we're done. How does that feel, everybody? Good. That's it. You did an exercise snack right now. That was easy. That's what you can do in your office because we all have sedentary jobs. I'm mostly on I'm lucky. I'm not a radiologist. I move around during the day. I don't look at a dark screen. I'm always on the go, so that's good for me. But more and more, my work is on the computer, right? Or it's on your telephone or something like that. But you need to move like that 4 or 5 times a day. Anytime you see staircase, take the stairs. Do not use the elevator. This all contributes to what we call NEAT. You know what? Has anybody heard the term NEAT before? Non-exercise activity thermogenesis, right? Exercise doesn't burn that many calories. All the other activities you do during the day. It's all that fidgeting, the walking, going upstairs. It's super important, actually. And that's what improves your metabolic health. Okay. So let's calculate my biological age, okay? So these are my metrics. Okay, so I have one of these wearable devices that I wear it all the time. I find them, I've been using it for the last 6 months, and it's giving me a wealth of data. So my resting heart rate is between 48 and 50. That's what it says. And my heart rate variability is between 70 and 75 milliseconds. So that's the beat-to-beat variability, because your heart doesn't only beat on the same time. It changes with stress, with the nervous system, all of these things, so it changes. And the reason why HRV is useful is we have algorithms that then can predict your total VO2 max. So if you have an Apple Watch, it'll do it. Or if you have a Whoop or an Oura Ring, they all calculate this data. It's really interesting. My lean body mass is high. I have one of those scales. Maybe Dr. Racha uses it, like, you know, those biometric scales. They use conductance, and I can see it's a good thing to follow, basically. It's not as accurate as MRI. That's the gold standard, or DEXA. But it will tell you what you're made out of, how much water, how much bone, how much protein, how much skeletal muscle is there, lean body mass, and how much body fat is there. And then you put all this data into an AI calculator. And the way the calculation works is because we have this data from Whoop and all these rings, we know what the baseline is for certain age groups, correct? So let's go through the calculation a little bit. So this is the experiment that I did in December. If you can appreciate this this graph here. So my constant is my resting heart rate, my HRV, and I maintain my muscle mass. So what happened? I was at the beginning of December somewhere between 22 and 23% body fat, right? And since January, what happened was I reduced my body fat almost, actually it's 19% right now. So this was the last data that I put in. So, and then my goal is to get to 18% body fat. That's just my personal goal, because we'll talk a little bit about why visceral body fat is so bad for us. So what ended up happening was, because my resting heart rate is 48 to 50, actually I'm in the percentile basically of a 25-year-old who's actually fit. That's their resting heart rate, right? And my HRV is 70 to 75. I'm also in the range of something about 25 to 30 years old. Where my number goes up is my body fat, my visceral body fat. I'm actually around my current age. So that gives me around a biological age around 32, let's say, to 35, something around that age. So who predicted that? Raise your hand. Fantastic. Thank you. You're good. You have a good intuition. Good future doctor here. Yeah, so around that age. And if I do hit the 18%, it's going to show me as a biological age of 29 from a fitness point of view. It's not taking into account other diseases that I may have, but I don't have any of those other ones right now. So that's an interesting thing that you can put in this data inside an AI calculator, and it has access to all this demographic data from all these devices. So basically, what is muscle and why is it the largest endocrine organ? So what's the main danger, right? So when you see a man walking down the street, you know, why is his belly like pushed out? It's not because of this like subcutaneous fat that you can pinch, okay? It's actually the fat inside the organs that's on your liver, your pancreas, even your heart. That fat is just pushing your abdominal wall out. That's why you get that pot belly. So that visceral fat, that's basically like a metabolic bomb, you could call it, right? Or a toxic bomb. Because it secretes all these inflammatory cytokines, particularly IL-6. And there's a theory called the portal vein theory, where all that those fatty acids that go basically directly into the liver, and then you get shot. It causes a lot of insulin resistance. And insulin resistance is bad because then you start developing metabolic syndrome and all the other cascade of diseases. So why is muscle then really important? Because that is the counteraction, right? Muscle basically just destroys visceral fat. Acutely, when you exercise, you secrete good cytokines like IL-6, which are anti-inflammatory. You take up all that glucose into your muscle that could be insulin mediated or not insulin mediated, right? Because glucose is not good, I would say, in a sense, if it's not in the cells. If it's not in the cells, it glycosylates all your proteins, and then that leads to all kinds of disastrous effects in terms of longevity. So if you have a lot of muscle, right, you dispose of all of this glucose, you lower insulin, and you shut down inflammation. And I would argue that the only other thing I have to say about nutrition, it's my own personal thing that I do, is I generally don't eat anything after 6 p.m., 6 to 7 p.m. And my point of view is you should eat when the sun is up and stop eating when the sun is down. The reason being is that your body is preparing for sleep in the evening and secretes another hormone called melatonin. So for those of you who know, you can take melatonin supplements, but melatonin has a direct inhibitory effect on the pancreas, and it decreases insulin sensitivity. So you don't want to go to sleep with a full belly and a lot of glucose hanging around doing all its negative effects. So that's one of the reasons why we talk about this. There's clear biological mechanisms around this. So here's my prescription for you all. So a lot of people focus on what we call walking. Like this is like a whole army of walkers. Everybody's doing 10,000, 20,000, I don't know, 30,000 steps, which is great. They're doing a lot of flexibility, yoga. Those are all fantastic, or even just zone 2 cardio. But these utilize type 1 fibers. So those things are maintained as you get older. Your endurance remains. But you won't build any strength because we know every decade your muscle mass decreases. So you lose type 2 muscle fibers, which are the fast twitch strength. So if you lift weights or some kind of strength training, you fatigue those muscle fibers and then you stimulate them. And the prescription is easy. It's 2 days per week is the floor to maintain health. I would argue 3 to 4 days is optimal for body composition and health. And then finally, I'll conclude by saying that if you're not physically fit, everything fails, right? Your mental fitness, your financial fitness, your spiritual fitness, your foundation must be strong. And we say a lot of the times that health is wealth. So I have a question for you all. Who here, be honest with me, who here doesn't have time for exercise? Let's be honest. Dr. Kashi, doctor. Okay, so my question to you, if you don't have time for physical fitness, do you have time for physical illness? No, you don't. You don't have time for physical illness, right? Right? And you're going to be investing much more money into that, right? So, that's the point I'm trying to make, is that here's a population in Canada. We only spend, because we have we have public health care. Most people only spend about somewhere between approximately $1,000 a year on health. That includes prescription medicines. That includes like your eyes, your dental. It's all maintenance, but there's nothing about there that's preventive, right? And that's what we've been talking about here today, is really like, shouldn't we be spending more of our hard-earned money on our personal health and doing some of these testings that we're talking about here today that are going to be offered here at CYMED, for instance? That's my personal pitch for that aspect. I think that's important, and like that's the psychological shift that I've gone through over the years. So my only other thing I want to say is I want you all to eat healthy. I will make one point that I think protein is important because protein acts like a GLP-1 in my opinion. It satiates you. So the 1 gram per pound, if you're training, I think that's useful. If you're a couch potato, eating that protein is just going to get converted back to glucose through gluconeogenesis in the liver and then fat eventually. So you need to be very active to kind of take those things. Empty your suitcase, train twice a week. It's not a big deal. What did I say? What was the number that I said? What was the time? Anybody remember? 30 minutes to 1 hour per week, nothing. And then what's the last thing? Exercise snacks. How many? 3 to 4 a day. Just walk up and down the stairs, do some air squats, do a push-up, whatever you're able to do. All right? So I'll leave you with that, guys. Only the last slide I thought was maybe interesting for you all. I'll just leave it for you. This is my current regime and my current stack, as we say. All right, this is what I do. My goal is to reduce visceral body fat, right? And increase muscle. I feel much more healthy. You know, it helps me do all the different things I need to do with the father, whether it's my medical practice or my other ventures that I'm working on. I want to be full of energy. I don't want to be tired. And my current plan is I want to be athletic. I want to reach 15% body fat by mid-March 2026. That's my personal goal. I've never been that fit before in my life. I've always kind of been skinny, chubby, fat, something around that line. And this is my nutrition. I eat 1,800 calories a day. That's twice a day I eat. Okay. I get 170 grams of protein per day. I eat minimal processed food. I'm thankful. My wife, she cooks at home. I'm a strict vegetarian, so that works out well for me. I train 6 days a week for not long, 20 to 30 minutes. That's it. That's it. I do strength training, conditioning workouts. And then in the morning, life's easy. I take salt water. That's it. I take creatine, glutamine, and some multivitamins and a magnesium for sleep. I do know that my sleep needs to be optimized, but I have a small baby. It was very difficult. Not much I can do about that. And I would like to incorporate omega-3s in my diet. That's one thing for my brain health and my cardiovascular health that I haven't started yet. But I'm trying to figure out how to do that and incorporate that. But these are all what I call low-hanging fruit. And I personally have tried these molecules, and I want to see what it does for me, right? And they're all been studied. There's lots of exercise science around them. And that's sort of, I just wanted to share that with you from my own personal health journey. So thank you very much.
Any questions? Yes.
You said you were vegetarian. So a gentleman here was sharing that he was a vegetarian for some period of time, and then every time he went to get a blood test, they thought you were anemic. Or to give blood, you were too anemic. And then you returned back to a non-vegetarian diet and it improved? Yeah, it's possible because you might have been deficient in some vitamins like B12 or something like that you might have been getting from some of those other things you were eating. But it's not directly related to, there might have been a micronutritional deficiency. So a common causes of anemia are iron deficiency, B12, or some other kind of causes that are potential. Yeah, it could solve the problem potentially for you. Yeah, but that's why I recommend a multivitamin for everybody. It covers your bases because I don't know how everybody's eating, but if you're getting all those micronutrients, I think that's very reasonable. And there's more and more studies that look at multivitamins and cognitive health, so that's been very nice. Yeah. Yes, sir. Yeah. Yeah, absolutely. You can train VO2 max. So what happens when you train, you improve what's called your stroke volume. Every time your heart contracts, you can eject more blood, so it doesn't have to beat as fast, right? Your blood pressure drops, so you're not beating against a very high blood pressure. That makes it, because you don't want your heart to become too thick. That's not good. When it's too thick, that's what we call concentric hypertrophy. The heart then needs more oxygen to operate, and that'll potentially lead to a heart attack, especially if you already have blockages, for instance. So there's good data to suggest that children and youngsters, teenagers can lift weights, can exercise without any negative consequences. There was always this theory that if kids, for instance, started lifting weights, they would prematurely close their growth plates and that would stunt their growth. But that's not been the case at all, right? We don't stunt kids' growth through training. And it's such a good thing. Like, think about it. And the only other thing I failed to mention was like the cognitive benefits of being active. Who here has ever run before? Yeah, what's that high you get at the end of running? It's called the runner's high, right? It's the secretion of all these endorphins and all these good molecules going to, basically we call them hope hormones. They go to the brain, you feel good, right? And there's so many studies that have been shown that exercise is basically equivalent to treat depression in patients, like equivalent to SSRIs, for instance, those antidepressants that basically 25% of the population is addicted to. So get out there, you know. Yeah. Yes, sir. Yeah, so what do I do personally? So there's protein in basically 2 meals, and I substitute it with a whey protein shake in the afternoon. That's the easiest way for me to get that without dumping a lot of calories into my body. And like you said, you can find which one is good for you and which one actually you could stick with, you know. That works for you. There's so many, I mean, there's so many brands out there, but yeah, that's what I do personally. Yeah. Yes. Really? Push-up challenge for the Canadian mental health. 2,000 push-ups. That's amazing. Yeah. Yeah. Yeah, that's fantastic. I agree with that. Great. I think, oh, last question. Sorry, say that again? Yeah, all those hormones that we talk about. Yeah. Yeah. Thank you all for everything. I'm going to give the microphone back to Dr. Schwa. Thank you.
Thank you, Dr. Sairam. So please don't leave. We have a nice dinner and we have 4 winners for tonight. So hang on there. So as we come to the end of today's program, we would like to sincerely thank all of you for being here and for helping make this first Longevity Day in Montreal a success. Thank you to our speakers for sharing their expertise and to all of you for your engagement and thoughtful participation. We're very grateful to the CYMED Clinic team for hosting us and for their support. And we would like to extend a special thanks to Dr. Cyrus Shanbidi, Shireen Alemi, Victor Pitt, and Parza Rez. Where Shireen and Victor and Parza and Dr. Cyrus. This day reflects what can be achieved when communities come together around prevention, health, and longevity. Before we say goodbye, so yeah, we're collecting the names for the raffle. We'll go to the 3rd floor for dinner. We'll withdraw the raffle there. Shireen, can we take the stairs? No? Okay. If you need a snack exercise, you can take the stairs. If you don't need a snack exercise, we take the elevators. Thank you, all of you. And please follow Synapses Wellness Hub for more events. I feature all events around Montreal and Quebec for now. Thank you.
At Ebovir Biotechnology, we're redefining precision medicine through AI-driven genomics and Health Canada and FDA-approved diagnostic tests. Our private lab integrates digital PCR, whole genome sequencing, and AI-powered screening to detect disease early and guide personalized healthcare. With a Santé Quebec certified lab, proprietary analytics, and a growing clinical research network, we provide fast, accurate, and clinically meaningful results. Our tools provide doctors the insights they need for prevention, targeted treatments, and long-term care planning. We work with healthcare providers across Canada to bring precision medicine into everyday clinical care. At Ebovir, your genome is more than just data. It's a blueprint for lifelong health. Ebovir, precision medicine made personal.
Bienvenue à la clinique CYMED, où la médecine moderne rencontre des soins personnalisés au cœur de Montréal. Chez CYMED, nous croyons que les soins de santé doivent être simples, fluides et centrés sur vous. Qu'il s'agisse d'un bilan de routine ou d'un suivi régulier, nous sommes là pour que chaque visite compte. Notre équipe de médecins de famille expérimentés propose des consultations en personne et virtuelles, conçues pour s'adapter à votre horaire et à votre mode de vie. Pas d'attente interminable, pas de paperasse compliquée, juste des soins rapides et de qualité, exactement quand et où vous en avez besoin. Pour ceux qui recherchent un soulagement expert de la douleur, CYMED offre aussi des traitements avancés, incluant des injections au genou, des thérapies pour la colonne vertébrale et des programmes personnalisés de gestion de la douleur, délivrés avec précision et attention. Nous sommes également fiers de servir la communauté d'affaires avec des examens médicaux, pré-emploi, des bilans de santé pour cadres et des services complets de bien-être pour employés. Parce qu'à la clinique CYMED, votre santé n'est pas qu'une priorité, c'est notre engagement. Prenez rendez-vous dès aujourd'hui sur www.cymed.ca. Découvrez des soins qui vont plus loin.